Hello, everyone. I'm Dr. Diana Morse, Director of the University Center on Aging and Health at Case Western Reserve University and the School of Nursing. And it's my pleasure to welcome you all here today. I wish we could be in the same room together, but next year we're planning for that. This is how we're staying connected and engaged during the pandemic and keeping the work of the Center on Aging and the Cellar Conference in front of you. I want to welcome you today, and not only do we have many friends and colleagues from Ohio joining us, but we actually have people from 17 other states and Washington, D.C. So welcome to everyone. I wanted to, first of all, thank the School of Nursing and particularly Lucinda Cave for working on the CEs, or as we now call them, CPDs in nursing for the session. And also I want to thank Western Reserve Area Agency on Aging, specifically Danielle Clay, who has worked on preparing and providing us with social work contact units. So thanks to both of those organizations for their ongoing support. I wanted to just mention who the conference is named after, Miss Florence Cellar. She was an alum of the Francis Payne Bolton School of Nursing. She graduated with a master's in nursing in 1938 and spent the next 40 years at university hospitals, first as a staff nurse and then as an administrator, and retired from nursing and being a clinical teacher at the School of Nursing in 1977. In 1982, she endowed the Cellar Chair in Gerontological Nursing. It was the first endowed chair at the School of Nursing. We have quite a few more now, but she started it off. And it was also the first chair in Gerontological Nursing, not only in the United States, but across the world. And since that time, we've been honored to have early on many visiting professors who were visiting Cellar professors. And among them is our esteemed speaker today, Dr. Terry Fulmer, and also permanent professors in that position, and I think she's with us if she got the link right today, is Emerita Dean and Professor and Emerita Director of the Center on Aging, May Weichel, who many of you know. I just finished serving in that chair, and now Dr. Evelyn Duffy, who you'll hear from later, is the new Florence Cellar Gerontological Chair of Nursing at the school. I think today's topic is particularly important and relevant to all of us who are working with older adults, and especially as we're coming through and heading into whatever our future and new normal is with the COVID pandemic. And even prior to that, those of us who work with older adults have known we're in a changing environment that for the future is going to look very different from what we're used to in terms of providing care and services to seniors. And the need to address what that's going to be has been exacerbated by the fact that during the pandemic, older adults were disproportionately affected by COVID, and especially older adults of color and indigenous older adults. And so it challenges us to look at the opportunities and also the barriers and needs to break those barriers of providing models of care and service to seniors that support their well-being, support their health, and are supportive to their families as well. So this disruptive period we've been in, if you believe in the disruption theory, has accelerated the challenges and the opportunities and accelerated the change we're going to see in care provided older adults across the spectrum of care, from acute to community-based care of all kinds. Some we probably haven't even envisioned yet. And so it's I'm particularly glad that we could address the model that John A. Hartford has been developing and supporting, and that Dr. Fulmer actively supports as part of the mission of the Hartford Foundation, that addresses a way of providing care to older adults and meeting their needs across the spectrum of where we meet them in our communities. So I will now turn over, and I should say a housekeeping item. You will You will get evaluation forms to get your CEs after. We will email them to you after the conference. So in thinking about this disruptive environment, I would now pass the discussion over to Dr. Mary Dolansky, who's the director of the QSEN Center and also the director of the Hartford Foundation CVS network working on aging-friendly health environments. So Dr. Dolansky, I'm going to mute my mic now.
All right. Well, thank you so much, Dr. Morris. So welcome to all at the first Florence Cellar webinar series. We are delighted to have you all here today. I will serve as moderator, and I am, as Dr. Morris mentioned, I am the director of the QSEN Institute and the Hirsh Institute, and also the co-principal investigator for funded from the John A. Hartford Foundation, Age-Friendly Health Systems Implementation into the CVS and MinuteClinic. And as moderator, I would like to just state a few things to orient yourself to the Zoom. If you would like to see the presenter only, then navigate up to the right corner of your screen, and there is a view bar there, and you can change your view to speaker view only instead of gallery, and then you'll just see the speaker speaking. And also, you will not be able to have a mic available for questions. However, there is a question and answer button you can pick or choose to put questions in. And then also, if you can chat a question in or a comment, I will be monitoring the chat and therefore will be interjecting to our speakers your questions. So please post in your questions. With that, the second piece of housekeeping, as the moderator, I want to just give disclosures. There are no conflicts of interest for anyone planning or presenting the activity. And learners who complete this will receive 1.25 of contact hours, or CPDs. Criteria for completion was that you listen and interact with the webinar, and then following the webinar, we will give you a link in the chat box, and the link is actually at the top of the chat box currently, for you to link onto and then complete and submit your evaluation within 2 weeks, and you'll receive an electronic certificate, and you can download that and print it to your convenience. Please save your certificate for your own records for 6 years, and note that our credentialing agency is listed below. Next slide. Great, so just to get us started, I just would like to do a quick poll. How familiar are you with the concept of age-friendly health system? And there we go. So if you can just click on your answer to that, it'll give us a little gauge of our audience and your familiarity with the concept and the initiative. Give you a few seconds there to complete, and then Maria will close out the poll and show us the results. Great. So about 18% of you are extremely familiar, 32% moderatively, somewhat 27%, and then 17% slightly, and 4 or 6% not at all. So thank you for that. It helps to kind of help us today for this discussion. And so now I'd like to move to the next slide, and we have a nice welcome from our Dean, Carol Musil.
Hello, and welcome to the 2021 Florence Cellar webinar series, a 3-part virtual event hosted by the University Center on Aging and Health and the Francis Payne Bolton School of Nursing at Case Western Reserve University. My name is Carol Musil, and I am the Dean at FPB. I would like to share a little history about Florence Cellar, for whom this conference is named, and who endowed the Cellar Nursing Professorship currently held by Dr. Diana Morris. Ms. Cellar was a leading nursing voice in elder care. Florence Cellar was an alumni of Case Western Reserve University, graduating in 1939 with her Master of Nursing degree from FPB. She spent 39 years at University Hospitals of Cleveland, starting as a staff nurse and rising to a leadership position in the Department of Nursing. Florence also worked at FPB as an assistant professor of clinical nursing before retiring in 1977. In her practice and during her teaching years, Florence saw elderly populations grow as lifespans increased. Recognizing the need for nursing preparation in this area, she established the Florence Cellar Professorship in Gerontological Nursing in 1982 in memory of her parents, Carrie S. and Wilson F. Cellar. This was the first chair in gerontological nursing in the country, and FPB's first fully endowed professorship. The University Center on Aging and Health is an interdisciplinary point at CWRU for building and maintaining excellence in gerontologic and geriatric research, education, and practice. The center's work is increasingly important to our society. As nurses and as healthcare professionals, our goal is to ensure that all populations have access to healthcare and resources that meet their specific needs and help them thrive as they age. To care for this population, we rely on the knowledge and research provided by groups like the Center on Aging and the John A. Hartford Foundation, a philanthropic organization dedicated to improving the care of older adults. We are grateful to be joined today by Dr. Terry Fulmer, a nurse and president of the John A. Hartford Foundation. She is a fellow of the American Academy of Nursing and a nationally and internationally recognized expert in geriatric care. Dr. Fulmer spearheads the Foundation's mission of advancing and implementing age-friendly care within health systems. Next Avenue, the premier PBS digital publication dedicated to covering issues for older Americans, named Dr. Fulmer as one of the top 50 influencers in aging. She has also been the recipient of numerous prestigious awards, including the American Society on Aging's 2017 Rosalie S. Wolf Award for her body of work on elder abuse. Later in today's program, you will also hear from FPB's own Dr. Mary Dolansky and also Ann Pohnert, Director of Clinical Quality for CVS MinuteClinic, discussing their collaboration with the John A. Hartford Foundation and their work on implementing the age-friendly healthcare 4M framework into retail pharmacy clinics across the country. Thank you all for joining us today. I am now excited to turn over the program to Dr. Terry Fulmer. Wishing you an informative and inspirational meeting. Thank you.
Thank you so much, Carol, for that lovely introduction and for all you do every day to advance the well-being of the nation by graduating so many fabulous nurses from your program. It's a renowned program. I am so honored to be with you all today and to talk about age-friendly health systems. On a personal note, it's very, very special to me because I did know Ms. Cellar and I was able to hold the visiting professor chair in her name when I was at Case so many years ago, brought by my dear friend May Weichel. So hello, May, I think you're out there and we all have learned so much from you. Next slide, please. The mission of our foundation is very straightforward. We are dedicated to improving the care of older adults. And we do that through three priority areas: by creating age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. And everybody in this program will resonate with those three areas as tantamount to successful health for older adults and their families. Next slide, please. Our age-friendly health system work builds a movement so that all care with older adults is age-friendly care. No matter where you are, no matter who's giving the care, care should be age-friendly. Whether you're in a prison system, whether you are in an ICU, we ask you all to join us and become age-friendly. We are guided by an essential set of evidence, which you'll hear more about later today, but those are best practices around the 4Ms. What matters to the older individual and their families? Medications, mentation, and mobility. You'll recognize that those 4 themes interact with one another all day long. If your medications are off, your mobility is likely to suffer, and maybe your mentation is certainly what matters. So the set goes together, and it causes no harm and is consistent with what matters to older adults and their families. When we began our work in 2015, and then really reaching out to IHI in 2016, we said that our goal was to reach 20% of health systems by 2020. So we set the audacious goal of 2000, and we have reached over 2,600 hospitals, practices, convenient care clinics, and nursing homes already. And we're moving our goal up for June 30, 2023, and we are very excited and we feel confident we'll make it. Next slide, please. So here we have our success of 2,068 hospitals, practices, convenient care clinics, and nursing homes who have joined the movement nationally. And I will also say internationally. We have over 30 countries who are participating in this work. And every day we learn from them, with them, and about them, which is very exciting, particularly when we think about the world today, how global we are, how COVID has shown us how interconnected we are. And so again, our spread, we hoped to hit 1,000. We're at 2,068, which means that this work is resonating with all of us. And for that, we thank all of you. Next slide, please. We have a growing number of partners, and I must say how excited we are to feature Case Western Reserve University, the Francis Payne Bolton School of Nursing, and our friends at the CVS MinuteClinic, who we'll hear from today. They're champions and they're heroes to me because they were first in. They had the stamina, strength, and vision to say, we'll try it with you, Terry. And I will always be grateful to you and always be so happy that it was you who became our first partners in this part of our work. So you'll see these growing numbers of partners. First and foremost, the Institute for Healthcare Improvement in Boston, Massachusetts, led by Dr. Kedar Mate, who is just a true champion of the work. The American Hospital Association, which now has a program on the next generation of leaders who are specifically age-friendly health system leaders, and all of you can apply for those opportunities through AHA. The Catholic Health Association, 1 in 5 healthcare encounters in the United States are with a Catholic health system. So we have been particularly grateful to Julie Trocchio and the Catholic Health Association, who right after we began our work, they started an age-friendly health system column in their magazine. And so I thought we better perform, and Julie's been great. You'll see Project Echo, different states have joined us. Certainly we're grateful to everybody on the slide for what they're doing to help us and teach us. Next slide, please. It's very clear that we have a mandate. We need age-friendly health systems. Our demography is the greatest success story of the 20th century. If you were born in 1900, your life expectancy was around 40. And if you were born now, your life expectancy is around 80 or more. So this is magnificent scientific progress. But what we need to do is keep up with the care of older people, age-friendly health systems. So the demography is clear. The complexity is clear. And when we think about 80% of older adults who have at least one chronic disease, 77% having 2, most older people are on 5 to 10 medications. That's complexity. But we have found our 4M set to reduce the cognitive load and complexity by having people zero in on these 4 items in the set in order to arrange their care, their thinking. And yesterday we heard the VA, one of the VA systems in Alabama was telling us that they now do their rounds around the 4M framework. So that's exciting. Older people suffer from disproportionate harm from healthcare as compared to other groups. And I know that you all watched the horrific impact of COVID on older adults in nursing homes and those who are homebound. So we have work to do. We know how to do it. We have the science. Everything in our age-friendly health system work is built on scientific evidence funded by the National Institutes of Health, foundations, and other wonderful government organizations. We have the science. We have to put it to use in a reliable way. Next slide, please. So the evidence base is not applied reliably. What we know is that the evidence we have only reaches a modest proportion of those who could benefit. We know that with it, it's difficult to disseminate and scale models, difficult to reproduce in settings that have lower resources, and it may not translate across all care settings. So that is when you just take a program by program approach. What we do with our age-friendly health system is knit them together. How did we start? Next slide, please. We had a meeting in August of 2017, and I always refer to it as our FOMO meeting, our fear of missing out meeting. People came off the beach, off vacation to join us because we said we were going to meet at IHI and we were going to bring together CEOs of health systems and some of the nation's premier leaders in geriatrics and aging. And we did come together. And in that meeting, we queried one another about what our goals were, what we wanted to have happen. And so that was the beginning. And then what happened is the IHI team got together and they looked at all the different models of care that are out there. Niche, for example, the ACE units, the different programs such as Help, Boost. And they found that they could identify 90 care features in those models. There were redundant concepts which were removed, and then they melted it down to 13 discrete features found by the IHI team. After the expert meeting, we came together again to select the vital few that everybody said these have to be in. And we got to the 4M framework. So that was quite a moment when you have people who are all very enthusiastic about their own models, but everybody agreed that we could come together with a 4M set. We could see ourselves in the work. And so that was a very pivotal time and got us moving right along. Next slide, please. So again, that 4M set, what matters, medication, mentation, mobility, is a driving force for us and one that is resonating not only in hospitals, nursing homes, public health systems, and we're beginning to work with age-friendly cities and communities to say the following. Can you really say you're an age-friendly city if you don't have an age-friendly health system in your city? And that also has great resonance with people. Next slide. So the evidence base, let me give you some examples. And new data comes out every single day. We have multiples. When you ask what matters with the people you're taking care of, we find that it lowers inpatient utilization by over 54% and ICU stays decreased by 80% with increasing hospice and patient satisfaction. Older adults and medications suffer adverse drug events at a much higher rate, and they can have morbidity and mortality from it. So we found that with 1,500 hospitals in the HEN project, we reduced 15,000 adverse drug events, saving $78 million across 38 states. Very powerful. Mentation, depression in ambulatory care doubles the cost of care across the board. And then there's a 16-to-1 return on investment on delirium detection and treatment programs, which has been found as well. Mobility, older adults who sustain a serious fall-related injury require an additional $13,000 in hospital operating costs and have an increased length of stay by over 6 days. So this data is compelling, and it really is the narrative that you want to take to your practices, take to your curriculum committee, take to your families and say, I want 4M care. Next slide, please. Why? Represent core health issues for older adults, build on evidence, simplifies and reduces implementation and measurement burden, and the components are synergistic and reinforce one another. Next slide, please. So the guide to using the 4Ms in care of older adults has been tested in ambulatory and convenient care, and we will hear from Anne more about that along with Mary. And so we started with our age-friendly health system model, thinking about how to assess and know older adults, and then incorporate the 4M into the plan of care, and you'll hear more about that shortly. Next slide. We also have a guide for hospitals and nursing homes, which also follows along a very plan, do, study, act, evidence-based intensive model, which is reliable. That's the key word, reliable. Next slide. So when we think about age-friendly health system measures, what we know is that there isn't a soul in clinical care anywhere who wants one more measure. They don't. We understand that. There's measurement burden. People talk about how they're in front of the computer all day instead of at the bedside, the euphemist bedside, whether it's in the community or in a facility. And so what we have done with our work is to say, what measures do you already have and how can we use them? So when we talk about access to care, we count the older adults who receive care, and we also capture their diversity, their age, race, and ethnicity. Faith Mitchell was speaking yesterday on that same Veterans Administration program I mentioned, and talked about how it's so important to be very intentional about understanding your outcome measures by age, race, and ethnicity so that we can get to equity for the care that we deliver. Access to care, counting the older adults and receiving care, and then thinking about your denominator. Access to 4Ms in the health system, counting older adults who actually get that 4M care as a proportion of all the people you take care of. Process measures, what matters is already a part of the ACP documentation. What matters documentation, so important and has really profoundly resonated with this nation and around the world. People understand that if you're not human-centered in your design, things will never go well. Medications, really watching closely for the presence of any of the 7 high-risk medication categories, which are well listed in our materials. And then mentation, screening and documenting depression, dementia, delirium, mood, memory, and thinking about mobility. You're screening for mobility and mobility enhancement, not just falls prevention. The outcome measures you have are your 30-day readmissions, your HCAHPS, your length of stay, your ED utilization, and delirium events. And so we use those as ways to follow your progress. Next slide. So equity and age-friendly, there's a picture of Faith, who is our age-friendly health system co-chair. And she does such a beautiful job. Faith was previously the CEO of Grantmakers in Health in Washington, D.C., and is now at the Urban Institute. So that she began our equity task force in 2020 to really look at our measures and say, are we recording this carefully for a racial and ethnic analysis, linking that collection with our data, analyzing the outcomes, and then following up to address any disparate outcomes. Therein lies the most important thing we can do. And she published a paper in Health Affairs about that. Next slide, please. When we think about implementation guidance, you can go ahead and click again because this kind of balloons out and again and again. There we go. One more, I think. Thank you. So our implementation guidance on the website at the Institute for Healthcare Improvement is strong, powerful, accessible, and ready to use. So we have our age-friendly guide to care, our toolkits, our business case for becoming age-friendly, which is the colorful portion in the middle, where you can plug in your numbers and get a return on investment. Our age-friendly guide to the electronic health record, where we've worked with Epic and Cerner to really think about the adoption of the 4Ms, and then our guide to record requirements. So all of these are there, they're free. You download them, you adapt them to your own setting, and then we always ask you, please tell us how to improve those materials because they are work in progress. The one other resource that I'm very proud of is we've completed a book called the Age-Friendly Guide Handbook, and we think that that will be available by December. And what it does is compile all these materials into one handbook for those who prefer that approach to getting your learning. Next slide. So we saw that the 4Ms were very helpful during the COVID pandemic and the continuing COVID pandemic, and that a telehealth visit that was surrounded around the 4Ms was very, very productive and well received by families and appreciated so much by clinicians who were stymied about how to really approach clinical care through telehealth. And so when you say, I'm just calling to check in with you, we know this can be a stressful time during this coronavirus, limiting our abilities to go out. How are you doing? documenting, let's review your current medications. Has your weight changed? Is your diet different? Are your medications okay? Mentation, it's stressful. Are you finding that you have difficulty with memory or any short-term memory problems? And how are you getting around your home? If you're able, I want you to stand and show me how you stand up and sit down, and making sure that you can do that safely. If not, we'll make sure that we figure out how we can best help you. So they're an example of how we found this to be a very interesting frame. Next slide. There's recognition for this work, which we're very proud of. Recognition from IHI, where hospitals, practices, and nursing homes can achieve 2 levels. The first level is participant, where where hospitals, practices, and convenient care clinics can describe how they're putting 4Ms into practice. And then there is commitment to care excellence, and you see the exciting numbers listed there, where data are coming in and we are following the work. Next slide. Older adults reached by 4Ms. We've reached conservatively more than 840,000 older adults through our 4M care. And a very nice quote we have is that, you guys have given me back my mother. And this was said by the daughter of an older adult after seeing the impact of mobility coaching, the Move and Groove program that's part of the 4M care at the University of Alabama Hospital. So a shout out to the University of Alabama. Next slide, please. Providence is a wonderful example of a health system that is going full tilt around age-friendly. And I was invited to give a keynote today at the same time as I'm speaking to you, because Providence is going live 100% of their system today. And Amy Berman, who is my absolute day-to-day, minute-to-minute partner on this work, is giving that keynote today. And Rod Hochman, the president of Providence, the CEO, and they are in over 30 states, is making the opening remarks that they are committed 100% in all their facilities, much like we've been able to see the enormous commitment by CVS that you'll hear about. So they have their guides and an advisory council. They have outpatient and mobility programs, trained provider champions, and a mini fellowship. And they found that when they use age-friendly approaches, that they're twice as likely to screen for fall risk and cognitive impairment, 4 times as likely to receive interventions. They are more engaged in what matter conversations. They've lowered their high-risk medications. And also they've seen a decrease in hospitalizations who have been seen at these mini fellowship clinics. So providers really say, these have been my best weeks since I left the chief resident year. I'm more connected to my colleagues and confident in my patient care and more hopeful about the future of medicine. Well, I'm always hopeful about the future of medicine. I'm hopeful about the future of healthcare, and I'm hopeful about the future of nursing every minute of my career. So next slide, please. Stanford Health is another example of a place that is just doubling down with great enthusiasm. And this is in their geriatric trauma program. And so they are asking what matters, medications, mentation, mobility. You hear the themes, but you see the different lenses that people are using, and they are measuring frequency. They're looking at the measures they use for consistency, and it's an all teach, all learn. If you join an age-friendly health system, action community, action collaborative, these types of data are shared hour to hour, if not day to day. And we're very proud of the work at Stanford. They have really shown us some tremendous work around trauma, and we've also seen work across their system. Next slide, please. Anne Arundel, one of our early pioneer systems, did wonderful work related to what matters. And they have practiced the 4Ms throughout their system and incorporated the 4Ms into their annual geriatric wellness visit, as Ascension Health did early on. And they've formed the prone and mobility team, which has been really important during COVID, especially in terms of oxygenation and thinking about social distancing and what they needed to do to connect with liaisons. And they said the 4Ms have improved the care of our patients in multiple ways throughout the pandemic. And Anne Arundel's patient satisfaction for older adults was in the 92nd percentile, where HCAHPS were in the 82nd percentile. So Barbara Jacobs, who is the chief nursing officer there, is a true pioneer champion, and a shout out to Barbara Jacobs, who makes our day better every day. Next slide, please. Another note for Stanford Healthcare just shows you that there are so many resources that are available to you. You can read about the case studies and outcomes on ihi.org/age-friendly. You can certainly access it through the John A. Hartford Foundation website. And these are examples of places that have just been so generous with their materials. And right there in the middle, that's our MinuteClinic, which we'll hear from in just a minute. Next slide. I'm asking you to join us. I want you to join our age-friendly health system movement. As nurses, we are the backbone of an age-friendly health system in every point of care. This is our work. This is our voice. Use your voice to make sure that we have age-friendly care. You can join an action community. You can access guides. We have do-it-yourself models for those of you who like to move programs that way. You can sign up for Friends of Age Friendly quarterly. We have tried to think of every way possible to provide on-ramps for each and every one of you to join us, participate with us, learn from us, and teach us, which is probably the most important thing I could say about working with all of you. It really, really helps. And my wonderful colleague, Marcus Escobedo, is chatting in the direct links for you in the chat and is also helping me with some of your questions and answers today. I will say that when I talk to families, I say, you deserve age-friendly healthcare. Please demand age-friendly healthcare. When you're in a clinical setting, say, can we talk about my 4 M's? It's a game changer. And everybody will say, sure, let's do that. It's brief, it's impactful, you can do it. Next slide, please. I want to express my profound gratitude again to the Francis Payne Bolton School of Nursing. I want to thank Mary, Diana, Evelyn, all the staff who have been so impactful, and to the dean for her lovely words, and for CASE for all the things they do to make the science and care of aging so much stronger every single year through their research, teaching, and clinical practices. So please know that I welcome you to join me on our web pages. There's my email, there's our website, and maybe you'll be seeing us on our NBC podcasts or on our WebMD pages. We're looking at every way we can to connect with you. And with that, let me close and thank you for your attention.
And thank you, Dr. Fulmer, for that inspirational and very informative presentation on the development and the facilitation of this very important initiative, Age-Friendly Health Systems. I think that I have been just so impressed with how quickly the movement is spreading across the country, and I think even internationally to some regards, because it is such a very simple implementation strategy, taking out that, I love that cognitive load of making it feel so difficult and simplifying it. We did have one question that we have a little time for, and that would be that how is the 4Ms framework adapted for implementation with older adults with cognitive impairment?
Mm-hmm. So let's go back to a 4M slide for a minute so we can all look at it. And it can be any of them that have they're right there. Look at the one with the 4 colors in it. So that would be maybe the next slide. Okay.
Oh.
I know, they're tricky. So let's think about someone with cognitive impairment. And what I will tell you is, when you have cognitive impairment, it does not mean you have zero capacity. Start there. You can have somebody with dementia or delirium who can tell you what they need. And if they can't verbalize it, they might be able to express it in the way in which they move or act. I'm a nurse. I see patients regularly. And I think that every nurse knows that when you have cognitive impairment, if it's profound dementia, you're going to have one approach. If it's intermittent delirium, you're going to have another approach. But if you have 4Ms, you will be focusing on that cognitive impact. When somebody is cognitively impaired, and I'm thinking about the nursing home patients that I've worked with over this past year, the worst thing was that they were in isolation. And so we did not know how much they were moving. And that can be held true in the acute care setting as well. And so really thinking about, if somebody had dementia, how frightening for them to be in a room that was closed when they were used to walking in the facility when they were used to seeing people, and all of a sudden seeing a mask instead of seeing a face. This has been a tragedy, but we will learn every minute from it. And I'm very proud that our foundation instantaneously funded the National Academies of Science, Engineering, and Medicine to do a study on quality and safety in nursing homes. We also funded the IHI to do a daily huddle in nursing homes, which has been picked up by ARC, and they are now using that curriculum in all 15,000 nursing homes in this country. And finally, we're working with frameworks to do reframing nursing homes so that we can understand the narrative. And I want to say the following: not all nursing homes are the death traps that they have been portrayed, but every nursing home is accountable. And so when I visited CASE and was a visiting professor there, they were part of the teaching nursing home program that was started by the Robert Wood Johnson Foundation. And I joined you at your teaching nursing home site, and I learned so much. And let me say, we're bringing that back, and we're going to be working in the state of Pennsylvania with the University of Pennsylvania Nursing School, Pitt Nursing School, and Penn State to test the model in one state to see if we can get traction back and get that into the hands of CMS, where we can get it fully funded and bring back teaching nursing homes with the robust power they need.
Wow, that's very impressive. I'm grateful that they're doing that. We definitely need that. And on the note of the cognition, I think from the MinuteClinic experience that I have is that just raising awareness about cognitive impairment, that there's so much unappreciated cognitive impairment, and the 4Ms have a step where we assess it and then can raise awareness about some abnormalities that might be, present. So with that, we'll move to the next slide, which then is another polling question. So you heard about the age-friendly health systems movement today by Dr. Fulmer, and which really encourages all healthcare settings to deliver care that is specific to the needs of older adults. And as you heard, the age-friendly is evidence-based, and it's a framework known as the 4Ms that includes what matters: medication, mentation, and mobility. And then it is, the question then for all of you is your healthcare setting currently using the age-friendly health systems approach? So we're just curious as to how much of the age-friendly health systems you're currently implementing. We'll take a little time. And with this transition, I would like to thank Dr. Fulmer again for that excellent description of the development and the movement of the age-friendly system. And I think you'll stay on.
Oh, yes.
Okay, excellent. So we may have time for the end, more questions as we move forward. So
absolutely,
we'll
open. Thank you.
All right, thank you. And then Maria, if you want to show us the polling results. Okay, so about 42% of you have started to implement. Yay, that's right. All right, so we'll move to the next slide, and we'll move into an example from the Case Western Reserve University and the MinuteClinic. And our presenter will be Ann Pohnert, who's the director of the clinical quality at the MinuteClinic, and also a co-principal investigator of the grant that we currently have for the academic clinical partnership of implementing the 4Ms into the MinuteClinic. So Ann, welcome.
Thank you so much, Mary. And thank you, Terry, for that amazing history and description of a really impactful program that's making a difference around the world for patients everywhere. And I look forward to seeing a few years down the line where everyone is doing it and it's just part of our care. Next slide, please. So I am excited to support and serve as co-principal investigator, as Mary said, for the Age-Friendly Health Systems Initiative, bringing age-friendly to the ambulatory care continuum that is part of MinuteClinic and the convenient care setting in CVS pharmacies. Next slide. We recognized as a practice, as a national practice, that we understood the impact of aging and our population shifts in this country, like Terry described. 10,000 people turning 65 every day between now and 2034. And we also, at MinuteClinic, we're starting to see an increase in the percentage of patients over 65 who are coming to our clinics. Next slide. So our clinics are currently actually in 35 states and District of Columbia. We just opened some clinics in the state of Washington this week. So 1,100 clinics in 35 states and DC. We're open 7 days a week. We have walk-in visits as well as scheduled visits. We have a weekend and evening care. We're really committed to quality as a part of our program at MinuteClinic, with 3,100 or more providers, NPs, and PAs primarily staffing our clinics using evidence-based practice in our guidelines. We are Joint Commission accredited. We're also designated as a Pathway to Excellence organization from the American Nurses Credentialing Center. Our visits tend to be less expensive than urgent care, an emergency room certainly. We use a lot of electronic health record transmission of data records to primary care providers. So we are one of Epic's #1 transmitter of records to maintain that continuity of care between our patients and their primaries. And we are absolutely committed to satisfaction for our patients with an overall satisfaction rate of 94% and a net promoter score of 94.1. Next slide. So MinuteClinic has had a long history, 21 years, not as long as many institutions, certainly not Francis Payne Bolton, but we started out with an initial retail clinic model that was focused on acute illness and how we could support people not seeking care in the emergency room for things that could be seen outside in their primary care, but where they couldn't get appointments and they needed help, and maybe in off hours or evenings. Over the years, we've added a number of new services, chronic care support, expansion of other services. We have certainly this year with the pandemic added quite a bit of telehealth services to our platform. And we are introducing something called Health Hubs, which is an integrated health hub destination at the pharmacy, at the CVS pharmacy, along with the MinuteClinic, able to provide more care for our patients who are coming into that building. We are proud to say that we are now committed to care excellence level for age-friendly health systems in over 600 clinics in our fleet, and we're continuing to work in 2021 and 2022 to make that 100% of our clinics. A lot of expansion of our current services over the last year, specifically focused on chronic care, COPD, obstructive sleep apnea, diabetes, and other things, and a lot of COVID-19 point of care testing, as you can imagine. Next slide. So age-friendly health systems is very much aligned with our purpose and our values and our strategic imperatives as a company. We are using a strategy at MinuteClinic and at CVS to create unmatched human connections to transform the healthcare experience, and age-friendly certainly does that with the 4 M's. Next slide. So Terry's already described a great deal of what these mean, and so our job at MinuteClinic, working with Case Western and with the help of IHI and with the support of John A. Hartford, was to think about how do you do the 4 M's at a MinuteClinic in a clinic setting, in an ambulatory care setting in a lot of communities. Next slide. So we very early on in 2018 joined an action community and learned a lot, just like Terry described. We used a lot of the resources on the IHI website to begin to understand what the 4 M's would look like at a MinuteClinic and understand what it meant to document a 4 M visit at a part of a MinuteClinic visit. We used a lot of frontline provider feedback. We started to tap on providers in Florida, in Maine, in Ohio to practice the 4 M's and start to learn what it meant, how to include it in the visit, how to document it. We conducted patient interviews. We developed some patient-facing materials, which I'll show you in a little bit. We also developed an orientation program and training content to help train our 3,100 nurse practitioners and physician assistants. And a big part of our project in our planning of launching the 4 M's was designing and building a template in our Epic electronic health record so that the workflow of documenting the 4 M's could fit right into the patient visit. And we also spent a lot of time looking at data analytics and understanding how we would measure the impact of introducing the 4 M's. Next slide. So all of these implementation strategies that we came up with in our plan were implemented over, were things that we designed in this 18-month planning period before we started our implementation program. So I'll go over and describe a few of these practice-based tools. Evelyn Duffy in a little bit is going to share the professional development work. Next slide. So practice-based tools. On the left side of the screen, you can see a little snapshot of our electronic health record work that was developed again with a lot of input from our frontline providers on how they felt that would be best to document the 4Ms in the context of a visit. I know Epic as a whole is now starting to look at how to include 4Ms in their foundational platform, and we're helping to use this model and share that with them so they know how to go forward in other settings. We also introduced a pocket card that our marketing team helped develop, talking about your future health, giving you a special dose of age-friendly care at MinuteClinic. We found patient interviews that it would be helpful for them to understand why we were asking these questions. So the pocket card we can hand to the patient at the beginning. On the back side of the pocket card, we have the first 2 questions for the PHQ-2, which is part of that screening fermentation. Next slide. We developed an age-friendly health systems roadmap, and this really helped guide us in terms of where our providers would be going and learning about age-friendly from an age-friendly resource portal, where a lot of resources were available for them to review, tip sheets to give them access to understanding how to get into the orientation module, an intranet site, other tip sheets and demos. So all of these things kind of came together as a way to begin to introduce age-friendly at our MinuteClinics around the country. Next slide. So our new employee orientation now has the 4Ms class, complete age-friendly training as part of every new hire coming to MinuteClinic. They go through this training moving forward, and it's really helps them to understand how we've introduced it as a practice. Next slide. So 2020 came, and our goal was to introduce the age-friendly health systems program through an implementation plan that we had worked out through all of that planning time. And in spite of COVID, and in the middle of June, we actually did our kickoff and began to introduce the program elements of implementing age-friendly care at MinuteClinic. And it consisted of a welcome approach and then ongoing professional development and all of the different tools that would help us become a committed to care excellence organization. Next slide. Our official kickoff was actually at the end of May. And one of the things we did was send out welcome kits to our staff so that they could get some of the beginning materials. Next slide. We had some initial conversation and communication about the value and the purpose of the 4Ms, sharing our best practice tips and other messages through our morning huddles and inbox messages. Next slide. And we had ongoing outreach throughout the summer and the fall to get feedback from our field. How are they thinking about the 4Ms through that orientation, and what could we improve through best practices, learning from our early adopters, our late adopters, and improving things as we went along. Next slide. So a part of our program was to track how many people were completing the orientation course as we went along, and how we were learning as they would give us feedback while they were going through their orientation course. Next slide. They would get a lot of provider feedback about how assessing what matters, for example, would help align a patient's treatment plan with their values. They would be reminded of different ways to constantly provide age-friendly care, recognize mobility in the midst of their visits. So starting to clue in and understand how those 4Ms could be a part of the MinuteClinic visit. Next slide. We had a very robust communication strategy with several different elements included here. Next slide. A big part of what we do is have a landing page where people can go and understand and learn more if they need to, kind of just-in-time information at the MinuteClinic. Next slide. We had regional champions. So we have 66 regions across the country in 5 different areas. And the regional champions were early adopters, people very engaged and interested in supporting age-friendly care at MinuteClinic. And they very quickly became our voice in the regional level to help the providers and the chair understand what we were doing and explain everything. Next slide. So we've now achieved our committed to care excellence in 39 regions. The next slide. And our journey has really been an amazing one with a ramp up of numbers of patients who've received total 4Ms care as we've gone. And you can see that progressive ramp there that shows how powerful it's become to include 4Ms care in our visits. Next slide. And a number of outcomes. I know Evelyn is going to share a little bit more about our video vignettes and grand rounds, other things that we've done. Next slide. And we have testimonials from the front line. This is one of our top age-friendly providers who shares that, you know, with her patients, she tells every patient 65 and older, we use a national screening tool in every patient to identify potential high-risk areas. Doesn't necessarily mean that you're high risk today, but I'm completing the screenings before I can finish our visit today. She explains the screenings. Most patients are willing to participate, and she begins to educate them on the 4Ms. Next slide. And I know we have a number of testimonials, but I think we're running short on time, so I'm going to pivot over to Evelyn Duffy. And thank you all for your time today. We look forward to sharing more about what's gone on at MinuteClinic through this exciting implementation.
And thank you, Anne, so very much. Very impressive. I know you're moving on year 2 then with really testing some boosters to really hardwire to ensure that every patient at a visit in the MinuteClinic receives age-friendly care. Very impressive. You've really embraced the culture of age-friendly health systems. And I think it has a lot to do with leadership. And you and Angela Patterson really need to be acknowledged for your amazing work on truly successfully implementing age-friendly health systems into practice. So thank you so much for your time today.
Thank you.
All right, we'll move to the next speaker. Before the speaker, though, a poll. Which of the 4Ms is most challenging for you or your organization? Or if you haven't implemented it yet, which M might be, you think might be the most challenging? So if you could just share your views on that. All right. And we'll take a look to see how you all scored on this. All right, what matters? Medication, and the top winner was mentation. I think that we have found that also in our work at the MinuteClinic, that measurement, assessment, and actions on mood or the measurement of depression and cognition or mentation it seems to be the most difficult. So we would agree with you, but we may have some solutions for you in our next presentation, and that is Dr. Evelyn Duffy. And Dr. Evelyn Duffy is a professor at the School of Nursing, also the lead on our age-friendly health systems MinuteClinic implementation for professional development. And lastly, she's the 3rd generation of the Florence Cellar Professor of Gerontological Nursing at Francis Payne Bolton School of Nursing. So thank you, Evelyn, and take it away.
Okay, thank you. Thank you very much, Dr. Dolansky. Next slide, please. So the charge to our team, the professional development team, was to come up with products that are engaging and informative. And also, and probably one of the most important things we've kept in mind is that it needs to be presented in a reasonable time frame, because MinuteClinics are very busy and their staff are very busy. And so it's important that they can go through these training pieces in a short period of time. I also want to let you know that I'm not in this by myself. I have a lot of partners on the professional development team. From Case Western Reserve University, I'm working with Elizabeth Zimmerman, who is an expert in simulation, with Barb Tassel, who is our CE provider connection, and also at MinuteClinic, Mary McCormick is been a wonderful resource for us in developing these products, and Sherry Greenberg has been our consultant from IHI. And then those people are all part of our professional development team, but we also depend highly on the entire tech team and the evaluation team to give us that amazing feedback. One of the reasons that we are developing products about age-friendly that maybe add a little bit more depth to the understanding of gerontological care is because the majority of MinuteClinic providers are family nurse practitioners. And family nurse practitioner programs in general don't have an opportunity to include a lot of in-depth gerontological content. So this is one of the challenges that we have to bring that into their understanding. So creating these engaging products, helping them to provide a foundation in gerontology, and really being efficient in our development. Other resources we've done in addition to those educational products are to help develop algorithms that will allow the providers in the MinuteClinic to understand how to act on the assessment that they do of the 4Ms, and also to develop a simulated visit in their in a gaming format that they can do a virtual clinic and interact with the patients and practice practice the skill set, and then ultimately that will be a measure of competency. Next slide, please. Our first product that we worked on was an orientation to the age-friendly 4Ms care, and this is a video. We had professional actors that we engaged, and we demonstrated the difference in a traditional MinuteClinic visit, which was an excellent visit. But then we contrasted that with how you integrate into that MinuteClinic visit the 4Ms care. And they were able to see, you know, the traditional visit and then follow it with the 4Ms care. And the module itself also included more information with these videos embedded. And everyone in the MinuteClinic has been taking that as part of their orientation. And I think earlier Anne shared with you more details about that orientation that they're utilizing. Next slide, please. We needed products to provide a foundation in gerontology, and an existing format in the MinuteClinic system was a grand rounds that are held monthly. And actually, I think they're held weekly, and we are included in it once a month. So we developed 12 grand rounds, and the first one was introduced in July a year ago, and we'll be wrapping up these first 12 in the next 4 months. We utilized this format to give examples of case presentations. We chose these common presenting clinical problems that you see listed here because they're the ones that are often seen in the MinuteClinic. So we could show how in a visit for cerumen impaction, for example, even in something like that, you could implement 4Ms care and address medications, mentation, mobility, and what matters most to the patient. Next slide, please. We also created video vignettes, and the intention of these video vignettes, they're very brief. Each one is only 4 to 6 minutes. We bundled them into 2 sets of 5 topics, and each set contains continuing professional development credit. They aren't mandatory for the MinuteClinic providers to participate in, but it does give them an opportunity to pick and choose what they may need more information about. And also, if they complete an entire set of 5, they get the professional development credit. And you can see these topics that we felt were important to expand on the 4Ms. Assessment of what matters. Initially, that was something that people had a lot of questions about. Interestingly, on the poll that you just saw, it's no longer really one of their big issues. They've all done a really great job of figuring out how to make sure they identify what matters most to the patient. Using the get up and go, we modified the traditional timed up and go test to fit into the setting of the MinuteClinic. Giving more information about one of the important aspects of developing understanding of mobility is to prevent falls, which can be so deadly and costly to the patient. And then mentation, how to assess mood, how to assess memory. And we also did things on the medication, reviewing the Beers list, and then looking at over-the-counter medications. That these MinuteClinics are in a pharmacy, and there's access to all kinds of over-the-counter products that may not be age-friendly. So helping them understand what some of those common issues are. Next slide, please. This is a snapshot from the video vignettes. We did it in a interview format with someone from from academics and gerontological expertise, and then someone from the MinuteClinic that are providers there. Next slide, please. As I mentioned, we made these additional resources. One of them were these algorithms to help providers know what to do, how to act on their assessment of the 4Ms. It's assess and act on, and there were a lot of questions about exactly what you do if somebody does, for example, score as moderately depressed. And the other thing that we developed was a 4Ms brochure that can be handed out at the end of every visit. It outlines aspects of the 4Ms and gives additional information that everyone can benefit from. And then there's an opportunity to write on more specifics if there were limitations in one of the Ms or any kinds of problems with the assessment. And finally, as I mentioned, we're developing this virtual clinic to help evaluate competency. So on the next slide, you'll see an example of each of those. This is one of the act-ons. This was the one for the mentation. I noticed again in our quiz that that's an area that people had a lot of concerns about, and that was also what we found in the providers at the MinuteClinic. So we hoped by providing this tool that it would give them more resources to know how to respond if there were positive results to the screening. Next slide, please. This is an example of our 4Ms brochure. And the next slide, I think, shows the back of it. Yes, and here is where we address each of the 4Ms. You can see that there's already existing act-ons for each one of these areas. And then there's a space for the provider to jot down any specifics for that patient. And our goal is that the patient will take this, share it with their family, their caregivers, and ultimately their primary care provider. So they can have that primary care provider, if they aren't part of the age-friendly system movement, begin to think about these 4Ms and how critical they are to the care of older adults. Next slide, please. And this is a snapshot of our virtual clinic platform that the tech team has developed. It's an interactive computer simulation, and working with, especially with Beth Zimmerman, who's our simulation expert, on coming up with scenarios and how we can have a realistic simulation of a visit in the MinuteClinic and incorporate the 4Ms, making sure that they act on all 4Ms every time and that the plan of care aligns with what matters most to the patient. Next slide, please. We've developed a website, the afhsresourceportal.com, and any of you that are on this call today can sign up on this site, and you will have an opportunity to participate in any of these products that we've created to help you understand more about the 4Ms movement and care of older adults. Next slide, please. And I encourage all of you to explore the resources that are available on the IHI Age Friendly Health System website. You see the link to that site here. And finally, you are all invited in the next slide to register for an action community. We invite you to join us, and it can be done on an individual basis, and there's no cost. And it's a wonderful opportunity to interact with many people across the country in answering issues about implementing an age-friendly health system wherever you are. Thank you.
All right, thank you so much, Dr. Duffy, for sharing the resources that we've developed through our work with the MinuteClinic and the age-friendly health systems. I think in summary, I don't see any questions. So if anyone would like to post some questions or post something in the chat box, please feel free to do so at this time. We have a few minutes for questions. But in summary, this was a webinar that covered the development and the current facilitation of the movement of the age-friendly health systems throughout our country. And then a case study with the MinuteClinic on how this age-friendly 4Ms was implemented in that last resources that are available to all of you. And they have, the Institute for Healthcare Improvement has developed a marvelous implementation kit to help. anyone in any kind of setting to implement the age-friendly 4Ms in. So I don't see any questions. So I think maybe we'll, the poll question is last. So today, if you could just share what you learned about the age-friendly health systems movement, and Maria will bring up our last poll to help us to learn about the impact of this webinar for all of you. And while you're completing the poll, please know that we are all available for questions, or if you'd like to talk more about getting involved, we are very happy to receive any emails or phone calls to that regard. So then, Maria, let's see how people are coming through. All right, great. So we had an impact. You're interested in learning more. That is wonderful. So we will post our emails in the chat box for any questions that you might have. And I also would like to share that the evaluation form for the continuing education is in the chat box. So you can click on that and complete the evaluation form now and receive your education credits. So today we came together to celebrate Florence Cellar through this first Florence Cellar webinar highlighting the age-friendly health systems. This was a special celebration, as notably 10 years after Miss Cellar's retirement, Dr. Fulmer served as the Florence Cellar Visiting Associate Professor of Gerontological Nursing at the Francis Payne Bolton School of Nursing. Both Dr. Fulmer and Florence Cellar embody a passion for gerontology to ensure that older adults receive the care that they deserve. Thank you, Dr. Fulmer. Thank you, Ann Pohnert. Thank you, Dr. Evelyn Duffy, for sharing this expertise today. I invite all of you to look for details for our second Florence Cellar webinar in this series in July. And we thank you so much for today for Zooming in, and I wish you all a wonderful day. Thank you so much.
Mary.
Thank you, everyone.